You're gonna, no, you're gonna introduce him. I'm just gonna, so to, Pam's hedging here for a sec. So to continue, I guess, an honored tradition, every year, some point during transplant grand rounds, the transplant pharmacy resident presents a topic. And so, here you go.
I had to, where is he? Renal, oh, yeah.
Yeah.
So,
So,
renal fellow got here.
oh, okay, you had to hold his hand.
We had the most direct route.
Jon Rek is presently our second-year transplant pharmacy resident, and he'll be completing his residency here in the next 2 months, and then we'll hit the job market. So this is his chance to present, I don't think data that we've created, but I know where they're going. Pam Maxwell.
Oh my gosh, you've already introduced him. Okay. So how many of you guys don't know Dr. Rek? You all know Dr. Rek. Okay, great. So Jon Rek is actually a graduate of Texas A&M University, a feat that it's not the proudest feat that we're proud of, although we're proud of that. He actually got really smart and went to UT for his PharmD degree and finished his PGY1 residency at University Hospital last year, and he is about to finish his PGY2 solid organ transplant pharmacy residency in June. And as part of their residency requirements, they have to present a pharmacotherapy grand rounds and then provide it as an encore for the transplant team here. So please welcome Dr. Rek. Today he's going to talk about desensitization protocols in kidney transplants and review the evidence to support that.
Thank you. The lights? Okay. All right, thank you, Pam. All right, so the learning objectives today, we're going to look at identify the effects of HLA desensitization and how that affects outcomes in kidney transplantation. And then we're going to distinguish the targets of desensitization that's going to lead to the modalities that we use to actually desensitize these patients. And look at some of these studies, some of the larger studies, and kind of the overall summary of some of the studies that have come out in the last decade or so to evaluate the outcomes associated with desensitization. And then lastly, recognize those challenges that we incur as a result of desensitization therapy. So looking first at kidney disease in the United States, it affects over 20 million people that have CKD, and the worst stage of that, end-stage renal disease, has been on a huge increase over the past 20 years at 600%. This is leading to a lot of morbidity and mortality, and even one of the highest expenditures as far as Medicare is concerned, and ultimately leads up to 90,000 deaths per year. So if we look at the options for patients who do have end-stage renal disease, of course, the primary option is going to be dialysis. And over 400,000 people undergo dialysis each year in the US, but that itself incurs a death rate of up to 20% per year. So it's not a great end-stage treatment, and then not to mention the decreased quality of life that these patients have being hooked up to a machine multiple times per week. And even from a payer standpoint, just that one patient on Medicare per year incurs a cost of greater than $80,000 per year. So ultimately, we'd rather have patients be transplanted, of course, because this gives the potential to restore a healthy and productive life. And over the past decades, our outcomes have become substantially better. So graft half-lives now in the deceased donor pool are about 12 years versus about 15 years in the living donors. So we can have really great outcomes, and these patients can have these kidneys for a very long time. And then even once you look down at it, $30,000 per patient per year for a kidney transplantation, substantially less than those patients who are maintained on dialysis. Looking here at patient survival rates by dialysis, and transplant, you can quickly see that transplant is the better alternative for a treatment modality. At 5 years, survival rates of over 85% versus just 35% of those patients who remain on dialysis. But there are some hitches with getting patients transplanted, of course, as you're very well aware, is the mismatch of the donor and the recipient pool. Looking here on the on the y-axis, we see patient numbers in the years over the past couple decades, and you'll see the blue line. We've seen an exponential increase of the patients who are needing to be on the kidney transplant list, showing here 95,000 in 2012, already up to nearly 100,000 in just the past 2 years. However, over the last couple decades, kidney transplant operation has been pretty stagnant at around 16,000 transplants per year. But those patients who are able to get transplanted have really great survival outcomes now. So looking here at 1 year, if we look at living donor and deceased donor, patient and graft survival outcomes are well above 90%. Going out to 3 years, our living donor and our deceased donor patients are about 90% or greater. And then even up to 10 years, still very good outcomes. So one of the other barriers that we have is limiting the risk of rejection, and we've really come a long way in doing this with our current immunosuppression therapy, to the point that the risk of rejection now is around 10% within 1 year of kidney transplantation. And when we talk about rejection, we're primarily looking at the T cell side of things, and that's where the majority of our chronic immunosuppression is focusing on this T cell rejection to minimize acute cellular rejection and then graft insult. However, there's the entire other side of the immunosuppression, which is the immune system, which is the B cell side, leading to antibody-mediated rejection. More recently, this has been prevented by cross-matching techniques that have allowed us to minimize the risk of acute antibody-mediated rejection to less than 4% at 1 year. However, by doing this, by limiting the number of transplants by this cross-match, we're leaving a lot of patients on the table that could potentially get transplanted otherwise. And this is a diagram that's looking at essentially immune system activation, and it's going to be our roadmap for the rest of the presentation today. So first we see an antigen-specific B cell that's activated by a T cell after presentation of an antigen, such as the allograft. The B cell matures and then finally develops into a plasma cell, which produces antibody, and it's antibody that essentially binds to the graft, leads to complement activation and a cascade of events that can ultimately lead to AMR and then allograft destruction. So looking more on a histologically standpoint here, we see here's our antibodies that bind to the actual allograft. Complement binds here. You have this cascade of events here, leading to one of which is a byproduct here called C4D that actually binds to the endothelium of the kidney. It's actually a marker for antibody-mediated rejection. This cascade of events ultimately leads to this complex called the membrane attack complex, which affects the endothelial cells and then leads to the graft destruction. So we look at how the body actually identifies self versus non-self. It's encoded with a highly diverse system of cell surface markers called HLA or human leukocyte antigen, those being of class 1 and class 2 that mark all the cells in the body and help distinguish self from non-self. In kidney transplantation and transplantation in general, HLA A, B, and D are the most important and the most associated historically with graft rejection. And an HLA locus can express any ones of hundreds of molecules, so you could certainly see that there's various ways that a person could become sensitized to any of these different HLA molecules. So the primary sensitizing events that we commonly think about exposed to non-self HLA antigen, would that be if pregnancy, blood transfusions, and then definitely prior transplantation, which could ultimately lead to the formation of anti-HLA antibodies, which may, and then ultimately may include donor-specific antibodies, which would historically preclude certain patients from being transplanted because of the high risk of rejection. So we're all pretty much aware of the PRA here, the panel reactive antibody here, but we'll just go through this quickly. It reflects the overall degree of sensitization and estimates the likelihood of a possible cross-match to a donor pool, not exactly the specific donor, but of an average donor pool, telling that these patients wouldn't be suitable for transplant. So a PRA of 80% would indicate that 80% of the deceased donors in the pool are not acceptable. And as you could imagine, because of that and the potential for risk of rejection, patients who do have a high PRA ultimately accumulate on the wait list and may not get transplanted. So because of those things, we do the cross-match, in which the donor T and the B cells are mixed with the recipient's serum. And a positive cross-match would then identify that donor-specific antibody, or DSA, are there and could lead to AMR. There's a multiple different cross-match assays that have been used, listed here. So the complement-dependent cytotoxicity CDC cross-match is a cytotoxic test, and this was one of the original cross-matching techniques for detection of actual antibody that's going to lead to a complement-mediated cytotoxic reaction. Was the original PRA test that could identify the breadth of sensitization in these patients, but it's the least sensitive of all these tests. The flow cytometry cross-match is used pre or post-transplant to detect antibody strength. And they use these fluorescence antibodies to identify the strength or the breadth of the antibody response in the cross-match. These are reported as a mean channel shift, and it's a lot more sensitive than that of the CDC cross-match, and it could indicate a more predictive value of actual AMR risk. And then lastly are the single antigen beads, which is the newest way to cross-match and leads us to the virtual cross-match, which could be used pre or post-transplant to identify DSA identity. So these could actually identify the actual specific antibody, because you have hundreds of these antibody beads that are coded with a specific antigen, that we could actually identify the specific antibody that would be potentially at risk for AMR. These are reported as mean fluorescence intensity, or MFI, and this is the most sensitive and then ultimately specific, because we can identify the actual antibody. So then what happens to all these sensitized patients? Well, currently on the list, 30% of all patients on that waiting list of that 100,000 patients have a PRA greater than 20%, and half of these, around 15%, have a PRA of greater than 80%. In the next bullet here, you can see that median waiting time is directly related to the patient's PRA. So those patients who are at least sensitized have a lower waiting time, but once we get into PRAs of 10 to 79%, the median waiting time goes up to 5.3 years, and then greater than 80% at 10 years. And keeping in mind that the mortality on dialysis is so high, this could lead to very potential adverse outcomes for these patients. Also, 6,000 patients that are currently on that waiting list have a willing living donor but aren't able to be transplanted because these patients have DSA to the donor and they're HLA incompatible. This graph here shows transplants per 100 patient years on the waiting list identified by PRA, and you can see those patients who are sensitized greater than 20% are getting transplanted much, much less frequently than those less than 20%. And the risk of all this, so the reason we do the cross-match is to prevent hyperacute AMR, which is deposition of the DSA on the endothelium within minutes to hours of the graft implantation, ultimately leading to a flaccid and a flaccid kidney that doesn't pink up, and ultimately could lead to graft failure and removal, which has largely been prevented more recently by proper cross-matching techniques. Acute AMR is the loss of graft function in weeks to months post-transplantation that may be due to complement fixing DSA. And it's a triad that involves the presence of DSA, may or may not include the deposition of C4D, and then histological evidence of allograft injury. Again, AMR typically in the non-sensitized population occurs less than 4% of kidney transplants at 1 year. However, it's different than the cellular rejection that we most commonly think about, in that it's pretty much refractory to the conventional immunosuppression, and up to 15 to 20% of them will lose their graft within 1 year. And then lastly, chronic AMR. This is the ongoing injury and progressive failure in renal function that can occur over months to years after kidney transplantation. It may occur due to pre-existing antibodies at the time of transplantation or de novo DSA that the patient develops to the allograft. It can be visible on biopsy. Overall presence of DSA results in poorer graft survival in these patients, even in patients who don't have an acute episode of AMR. So after successful treatment of those patients who actually do have AMR, greater than 40% still develop transplant glomerulopathy, which is the chronic lesion of chronic AMR, and that leads to a 5-year graft survival of less than 50%. So we see here that preformed DSA, which may be at the time of transplant, could ultimately lead to that complement cascade and the deposition of C4D, which actually oscillates over time, leading to endothelial injury, and then could ultimately lead to chronic AMR and transplant glomerulopathy, IFTA, and graft arteriosclerosis. And again, this may be a slow, indolent form of chronic AMR, or may occur as a result of an initial acute AMR episode and then ultimately lead to graft dysfunction over time. So then what are our options for these patients who are sensitized? Well, we could wait for a negative cross-match deceased donor, but again, we saw that at 10 years, or at those patients who had PRAs greater than 80%, the median wait time was 10 years, and some of these patients just might not make it that long. There's also kidney paired donation, which some centers are using. However, the match rates for those highly sensitized patients are still very low, and those hard to match individuals just end up building up on the waiting list as well. So lastly, will lead to our talk today is HLA desensitization, which is being able to reduce or remove incompatible anti-HLA DSA to eventually allow transplantation. And crossing that HLA barrier could ultimately increase the donor pool and improve outcomes for many patients on the waiting list who otherwise would not be transplanted. So again, we'll look at our roadmap here and we'll kind of identify the modalities that have been used. The primary modalities that are used have been modulation of the recipient's immune system with IVIG, antibody depletion with plasmapheresis, and B-cell depletion with Rituximab. Many centers, this is by far and away the most common modalities that are used among centers across the country. However, each center does things a little bit different and has different cutoffs for transplantation, which makes analyzing the data a little bit difficult. So first, IVIG, immune globulin, in modifying the immune system, is a monthly 2 gram per kilogram dose. And this was primarily introduced by the Cedars Sinai group, primarily to transplant deceased donor and then some living donor kidney transplant recipients. It's got multiple potential mechanisms of modulations. It's one of those drugs that probably does a whole lot that we don't really know how it works. But thought to neutralize and enhance the clearance of circulating DSA, maybe inhibit complement activation, and possibly induce T and B cell apoptosis. So here we've got IVIG and ultimately working at many different steps on our roadmap here. The next modality, antibody depletion with plasmapheresis. This is just washing the body free of these antibodies in hopes that we can decrease DSA. So plasmapheresis commonly used on an every other day approach with a low dose IVIG of just 100 mg per kg compared to that higher dose to replete the immune globulin stores in the body that might be removed on plasmapheresis. This has typically been what's used in the Johns Hopkins and the Mayo Clinic protocols for living donor transplantation. The mechanism of this is, again, to just remove those circulating DSA. And it usually takes subsequent treatments to reduce little by little the amount of DSA in the body. But what we commonly see is that DSA often rebound to baseline within a few weeks if the patient's not transplanted. Again, we see plasmapheresis just depleting the antibodies in the system. And then lastly, Rituximab at a 1 gram or a 375 mg per meter square dose has been used with various protocols as more centers have become more used to transplanting these patients. The mechanism of this is an anti-CD20 monoclonal antibody, and it's aimed at those maturing B cells. Importantly, though, it doesn't actually hit the plasma cells, which are those cells that are producing the antibody. But it does lead to a profound reduction in the circulating B cell in hopes that those B cells won't produce endoplasma cells. And we see here that the CD20 marker is on the B cell. Rituximab hits that and depletes the B cell. So we'll now look at the studies that have been have shown the outcomes in these patients. And the first of which here was done by the Cedars Sinai group, reported back in 2004, which was until very recently the first and only randomized control trial in desensitization. And they used the high-dose 2 gram per kg IVIG approach. This was a multi-centered, double-blind, placebo-controlled trial. Was really aimed at seeing what the effects on DSA was in these patients, not necessarily trying to increase the transplantation rate. So the population with this was 98 highly sensitized patients who had a CDC PRA of greater than 50% for 3 consecutive months, 65% of which had a previous kidney transplant. So we've identified that that was a highly sensitized population. So these patients got monthly infusions of IVIG 2 grams per kg up to 4 doses, and then 4 additional monthly infusions if transplanted. And if not transplanted, given another infusion at 12 and 24 months with the hopes of decreasing the PRA or in the cross-match and ultimately leading to transplantation. That was compared just to a placebo at the same interval. Importantly with this one though, however, the trigger to transplant or the transplant criteria, what the goal was not actually defined in the study. So this here, on the y-axis, we see PRA percent in the study month, and you'll remember, so 4 consecutive months of IVIG infusions. We'll see here that the placebo group, consistently higher than the IVIG group, we see initial decline in the PRA, but it rebounded at 6 months after initiation of this regimen. However, even though we do see that rebound in PRA, the transplantation rate does improve. And you'll see here, percent on the left of those patients being transplanted versus years on the right. And these lines start to diverge here at 1 year where those patients on the IVIG protocol kind of take off. So although the rebound in PRA did occur, there was some other type of immunomodulation occurring that allowed these patients to be transplanted. So what we see here, the results of this study, is that the transplantation rate in the IVIG group at a median of 2 years was 35% versus 17%, which was significant here. However, this was one of the first studies that did identify that these patients who then went on to transplantation were at risk of higher rates of acute rejection here. So at 2 years, 53% in the IVIG treated group versus what we would more commonly think of closer to 10% in those of placebo treated group. However, if you look at all the other outcomes, even though these were subjected to more rejection, graft failure rates were non-significant. 2-year survival was very similar. The patients in the IVIG treated group had a greater median serum creatinine, as you might expect with the increased rejection, but didn't reach significance in the low number of study population. And then overall survival at 2 years was very similar between the 2 arms. So take-home points of this, IVIG did decrease, but doesn't eliminate sensitization. There was no difference at 1 year, but it did increase at 2 years. And this was one of the first studies that we saw that desensitization was associated with more increased rejection. However, graft survival and those outcomes did not change. So looking at some of the summary of other high-dose IVIG studies that were performed similarly to this one, do remember though that many of these studies used a little bit different protocols and different triggers to transplant. And a lot of these, so the VO and the Jordan trials were all done with the Cedars Sinai group. But we'll see here that transplantation rates were higher than maybe 0%, which these patients might be subjected to, or if not, very low transplantation rates. And some of them were actually substantially high here, 87 and 93%. The initial Jordan study here did have a low 35% transplantation rate. And a subsequent one done in 2012 did have a very low transplantation rate where they actually saw really no change in PRA, and in some patients even an increase in PRA. However, what we did see in many of these studies is that the risk of rejection in AMR was substantially higher than what we're accustomed to seeing. But patient survival and graft survival at the average number of follow-ups here were still very good. So then the Cedars Sinai group looked to kind of modify their protocol with the IVIG protocol and add the addition of Rituximab in hopes to kind of decrease the time that it took for the desensitization protocol. So if you'll remember, the last protocol was carried out over 4 months. They wanted to use Rituximab in order to allow a more profound depletion of antibody and a decreased time of the protocol. They performed multiple studies. This is one of their larger studies, a single center retrospective study of 76 highly sensitized patients, both living donor and deceased donor, all with a PRA of greater than 30%, but 75% of this population had a PRA greater than 80%. These patients had a positive pre-transplant T-cell flow cross-match with the prospective donor or had DSA. And their protocol here was just a 2-dose IVIG regimen on days 1 and 30, Rituximab on days 15. And if these patients were transplanted, got an additional dose at transplant and post-op day 10 to 14. And then also patients received induction depending on their risk status, and then also at the time of at transplant, what their actual protocol was. Their trigger to transplant, or their goal, was a negative CDC cross-match and or a flow cross-match of less than 250 mean channel shifts. And they've kind of developed that trigger to transplant, or that goal, based on some of their previous study, where they've kind of developed this nice graph here, which on the left shows how they reported it as SFI, which this number divided by 20 is equal to MFI. So what we see here, that's compared on the y-axis versus mean channel shift on the flow here on the x-axis. So an SFI of 100,000 is equivalent to an MFI of 5,000. And they've reported, based on their, they've done more of these than just about anybody, and have identified that MFI of 5,000 is equivalent to a mean channel shift of about 200, at which point AMR is really unlikely. And you'll see here, as you get a little bit higher at the time of transplant, you're incurring more risk to the point where these patients who are CDC positive, who actually have that was our non-sensitive cytotoxic test, that you really do want to try to avoid those patients transplanting at that point. So the results of their study, they reported that all 76 of these patients were eventually transplanted after desensitization. And the mean wait time of those receiving a deceased donor transplant before treatment was 95 months. Once they did initiate this treatment, they were transplanted in only 4 months. And this regimen did lead to a significant reduction in the T-cell flow cross-match. In the living donor pool of greater than, starting out at about 180, reducing all the way down to 68. In the deceased donor from 162 down to 125. So if we think about where that lies on here, you can see the further we can go down, the less risk we're going to then incur. However, it's kind of a really variable response of what you see. It's kind of the general findings of many of these studies is you can't always predict who's going to respond. And we'll see here the T-cell flow cross-match in the living donors as well as the deceased donors, our flow cross-match here on the Y. Generally, overall, you can see that those patients with an initial low mean channel shifts flow cross-match were able to respond pretty well and be able to maybe get below what they call negative at 50 mean channel shifts. Some of the higher patients with flows were able to decrease, but it's really a variable response. You'll see some here that don't really change at all. So there's really a lot here that we still don't have a really great grasp on what's going on and how to identify these patients. So when they broke it down among the patients who were transplanted between PRAs of 30 to 79% and PRAs of greater than 80%, 63% of this, the less sensitized patient population, still had a positive flow at cross-match. So that positive flow, meaning they had a channel shift greater than 50, but it was, of course, met the trigger to transplant. In that population, you still had very high rates of rejection, of total acute rejection of 42%, AMR of 26%. However, none of these patients actually lost their graft due to AMR. In the patients who had a PRA greater than 80%, you'll see, so less of these patients were actually able to achieve that negative flow cross match. And we still saw pretty much equivalent rates of AMR, around 30%. But in these patients who had higher DSA, 6 grafts were actually lost due to the AMR. When they broke everything down, they saw that significant association of AMR and DSA transplant. So comparing patients with a DSA of greater than 100,000 SFI, which was equivalent to 5,000 MFI, if you'll remember, 59% of those patients suffered AMR versus just 12% in those patients who were less than 5,000. And ultimately, patient survival, 95%, graft survival at 84%, was pretty similar to what we would expect in the non-sensitized population. So take-home points, again, in this moderate term survival of up to 2 years, saw similar survival in these patients. However, the rates of AMR still do remain elevated with the addition of Rituximab. And what the authors introduce is that these protocols are unlikely to produce that true negative flow cross-match. And it's really trying to identify that risk of where your cutoff line is and what your trigger to transplant would be. Because the reduction of antibody below this critical level could prevent AMR from occurring. Looking here at summary of these high-dose IVIG and Rituximab studies, you'll see again, many of these were from actually the Cedars Sinai group. And you see transplant rates that were very high. But again, with all of these, we do incur a greater risk of rejection, but again, which ultimately turns out to fairly decent patient survival and graft survival outcomes. However, there were 2 more recent studies done in the past couple years that did show very low rates of low transplantation rates. And both of these studies also identified that they really didn't see a change in DSA or MFI. So it kind of led the transplant community to kind of wonder what this protocol was doing and how we could define if this protocol is actually doing us any good. So the Cedars Sinai group then looked to recently conducted the second and only other multi-center double-blind placebo-controlled randomized control trial in the desensitization population. And it was designed to enter 90 highly sensitized patients who were awaiting deceased donor transplantation, all of which had a PRA greater than 80%. The comparators in this group were, again, that same regimen, high-dose IVIG on days 1 and 30, Rituximab 1 gram on day 15. These patients all got CAMPATH induction. And then transplanted patients, again, received an additional dose of IVIG, and this time with Rituximab. The goal was the same. The trigger to transplant was the same in this group. So the goal was to enroll 90 patients. 15 patients were initially randomized between 2011 and 2012, of which 13 or 87% of these patients were transplanted. However, the study was stopped in July of 2012 per protocol due to 3 observed serious adverse events, one of which could be AMR. So what we'll see here, when they finally did unblind the study after these 15 patients were transplanted, you'll see that all 3 occurred here in the IVIG plus placebo group. Rates of delayed graft function were higher, AMR was higher, and then graft loss was higher in the patients receiving only IVIG. So 3 episodes here. 2 of these patients actually had a rapid rebound in DSA 1 to 4 weeks post-transplant, ultimately resulting in TMA and intense C4D deposition. 1 patient did have severe TMA, but no DSA. So we did see a profound increase in DSA in 2 of these, but still 1 of them didn't have any DSA and led to AMR. 2 of the 3 recovered after a treatment round of plasmapheresis and eculizumab, but still had significant impairment of graft function. 2 patients out of this entire 15 ultimately lost their graft at 1 year. 1 of these patients due to AMR, and then another patient in the IVIG placebo group due to BK nephropathy. And then 1 patient in the Rituximab group expired at 12 months due to a nocardia brain abscess. So there was a trend towards increasing the number and severity of early AMR. The majority of those occurred very early on after transplant in the IVIG placebo group. And a trend towards lower DSA levels post-transplant in the IVIG Rituximab group. They noted that in the Rituximab group, there wasn't a significant rebound in DSA like there was in those patients who were just receiving IVIG, which may suggest that depletion of these memory B cells that become rapidly activated upon antigen presentation might be the important modality here that's actually doing more of the work. So we'll shift gears here a little bit. We've looked at the high-dose IVIG, now shifting gears towards those plasmapheresis protocols. And probably the landmark trial here, and one of the ones that, the largest studies as well, was out of Johns Hopkins, which was the single center retrospective study, looking at 215 HLA incompatible living donors. It was over 10 years, so some of these patients were identified by CDC or flow and then single antigen bead, which was called the treatment group. They carefully matched these patients to a match controls at 5-to-1 from UNOS database, and made two groups out of those. Those patients who remained on dialysis only, and those patients who were on dialysis and then ultimately led to transplantation. So their protocol is a little bit different. It's the plasmapheresis protocol, which was an every other day plasmapheresis followed by the low dose IVIG. And they've got an algorithm depending on what the level of DSA is or cross-match at the pre-transplant and post-transplant indicates how many plasmapheresis sessions they'll get before and after transplant. When they initiate plasmapheresis, they also begin ProGraft and CellCept, and then in this study, Thymo or Diclizumab was used for induction. And their trigger to transplant was conversion to a negative CDC cross-match. So the average PRA in the population was greater than 80%. 30% of those had a PRA greater than 98%. And these patients had been on dialysis for over about 9 years before desensitization. The protocol led to successful desensitization in 98% of these patients. And you'll see here these patients required about 4 pre-transplant plasmapheresis sessions and about 5 sessions post-transplant. And kind of one of the staggering graphs here is what you'll see here, going all the way out to 8 years, looking at survival percentage on the left versus months here on the right, or I'm sorry, on the x-axis. You'll see that desensitization treatment was about had twice the survival benefit of those patients who remained on dialysis alone. Although the lines did cross here at about 12 to 24 months, the authors did note that looking at the baseline characteristics of these patients that they were substantially debilitated, and many of these patients had been on dialysis for a very, very long time. But ultimately what we see here is desensitization does lead to great long-term survival, kind of what we've seen good survival rates in some of the more short-term studies previously. So it offers a significant survival benefit versus these patients who ultimately would have high morbidity and mortality remaining on the dialysis in the wait list. And they noted that survival benefit was preserved regardless of those assays used. So depending on the time frame when they use CDC, a flow, or single antigen bead, those graphs all basically look the same. However, in this study, they didn't actually report AMR, but we would probably suggest that those rates were higher overall. So here, looking at summary of those plasmapheresis and low-dose IVIG studies. Again, transplantation rates were very high using these, so this was a more controlled environment using living donors. But again, we still see the same thing, rejections high, and then leading to still pretty good patient and graft survival outcomes for the most part. Then later on after that, many of these researchers have then added Rituximab using various different protocols where they have added that to the plasmapheresis protocol. Again, very similar outcomes here though. We still see that the AMR rates are still very high and really very similar results as the previous table. So those were the main modalities that has been used. So we'll now look at kind of one of the newer modalities that's been introduced. So looking at plasma cell depletion and why this might be a benefit, because that's the cell that's actually producing the antibody that could ultimately lead to graft destruction. So bortezomib has been the primary agent used here. It's FDA approved for multiple myeloma. For treatment in desensitization, it's used as the first cycle, or used as multiple cycles, which is a 4-dose cycle. The mechanism of this is that it binds selectively and reversible to the 26S proteasome in the plasma cell. And inhibition of this proteasome leads to misfolding of the protein, and then ultimately apoptotic cell death, and then eventually leading to a decrease in antibody production. So looking at how that works here, works on the plasma cell. Ultimately, the thought is to lead to decreased DSA. So there has been far less studies performed with this agent. One of the larger studies here was performed here. It was a prospective open-label study of bortezomib-based desensitization between 2008 and 2010 in 34 highly sensitized living donor kidney transplant candidates who all had a positive CDC cross-match. In this protocol, it was a very complex protocol that essentially included 1 to 2 cycles of bortezomib plus CellCept, plasmapheresis, low-dose IVIG, and thymoglobulin sequentially. If patients weren't transplanted by day 25 to 26, which was the end of the first cycle, the first total cycle of the protocol, they then went on to a second cycle, which was then a little bit different, that would allow transplantation by day 54 or 55, at which time those patients felt that, then they would then just be put on the deceased donor pool. The goal in this protocol was a T-cell CDC cross-match negative and a T or B-cell flow less than 200 immune channel shows. So desensitization was successful in this population in 85% of these patients. About 70% responded to that first phase and were transplanted by day 25 or day 26. 17% then went on to respond to the second phase and then were transplanted subsequently. You'll see here we show the T cell and the B cell flow cross matches initially pretty high in these patients and leading to profound decrease in mean channel shifts to the point that this is a negative T cell flow cross match. We still had incurred an increased risk of rejection, total rejection of 24%. AMR was a little bit less, but still higher than what we would normally see at 17%. And over the course of this study of approximately a year, patient survival was about 100% and graft survival 85%, but none of the graft losses were due to AMR. So these are just some of the studies that have been performed using bortezomib in various protocols. Again, we know that we're going to incur a greater risk of rejection using these, and that bortezomib isn't going to totally deplete the DSA. It's thought that many of these plasma cells are going to lie in bone marrow niche plasma cells that are actually going to be unable to be inhibited by bortezomib. So lastly here, we've seen a lot of the short-term results of these patients who are desensitized and looking at the increased rates of rejection, but what does that then lead to long-term results? So this was the Cedars Sinai group here, which is the first to produce actual 5-year data in patients who were desensitized and compared positive cross-match patients to a cohort of negative cross-match patients. Patients here all had a flow cross-match of greater than, all had DSA greater than 1,000. Those patients that were less than 1,000, they noted that they had 100% graft and patient survival at 5 years. So looking at all patients included, death-censored graft survival in the positive cross-match group was 70% versus 88% in the negative cross-match patients. So by 5 years in these patients who were desensitized, we've lost about a third of these patients, or lost about a third of the grafts. But they did note that graft survival varied and was dependent on the class of antibody. So we see here the class 1 antibody, graft survival was 85% versus just 62% in those patients who had class 2, either class 1 and 2 or just class 2 alone. However, what they did note, if you look at the Kaplan-Meier curves, those patients who had class 1 had a 7% graft loss at 1 year. So the graft loss with class 1 antibodies does incur right off the bat, but overall those outcomes are very similar to those in the negative cross-match. It's those patients over the long course that with class 2 antibodies that do have poor graft survival. They also broke it down by strength of DSA and saw better graft survival in the class 2 MFI. So those patients who had an MFI less than 3,000 had very similar graft survival that had similar graft survival to that of the negative cross matches and the class 1 antibodies. But once you got above this 3,000 MFI cutoff, that's what brought down the graph a lot. And then lastly, looking at that chronic antibody-mediated rejection and those chronic lesions of transplant glomerulopathy, those patients who were negative cross-match, 9% at 5 years, class 1 and class 2 still had very high rates of transplant glomerulopathy, although some of these patients still did have decently functioning grafts. But essentially, the takeaway from this is that at 5 years, you lose about a third of your grafts, and then about another third of these grafts have transplant glomerulopathy, which may or may not be functioning well, and then a third are histologically intact. So lastly, just real quick, we'll look at the challenges of desensitization. Obviously, a center that's going to begin a desensitization protocol would have to identify pre-transplant identification of these patients and then risk stratify high-risk patients to identify that immunologic barrier that they're willing to undertake and then ultimately manage. So what is your center's trigger to transplant going to be? Because we do know that there's going to be a generalized increased risk of AMR and graft failure with increased baseline, and ultimately the center would have to identify what cutoff they're willing to undertake. And then post-transplant, aggressive post-transplant DSA and biopsy monitoring to try to hit the problem up front. And then lastly, be ready to treat AMR. So we've seen that all of these studies, no matter what protocol we've used, we know that DSA at the time of transplant is going to increase the risk of AMR. So all of the studies have really reported averages of about 20 to 25% or greater versus 4% or less in the non-sensitized patients. And then treatment is going to, treatment of antibody-mediated rejection is its own grand rounds talk of in its own, and trying to find the ultimate way of how to treat these patients. And then outcomes, so we see reversals gradual, patients might lose graft function, and then we saw that a third of these patients are still going to have these chronic lesions of transplant glomerulopathy at the end of the day. Real quick, lastly, from a pharmacoeconomic standpoint, we have to think about the cost of these things. And the guys at Cedars, Sinai, they did an economic cost evaluation where they showed long-term savings despite the high initial cost of desensitization. So they looked at a per protocol group where in their protocol, 71% of the patients actually were desensitized in transplant. And in that group, they included all the cost of drugs and protocol meds for desensitization. They also included all the costs for treating AMR, as well as those patients who had graft loss and then went to dialysis. Included those all against those patients who remained on dialysis and still saw a cost savings of over $20,000 per patient treated at 3 years. And then the newer agents that are coming out, the proteasome inhibitors, are going to require further pharmacoeconomic studies because those have yet to occur. So in summary, HLA sensitization is a significant barrier for kidney transplantation. And we've seen in many of these studies that it is effective in improving the transplantation rates. However, you're going to incur higher rates of acute rejection in AMR versus those than you would see in non-sensitized recipients. However, what we do know, especially from the Montgomery study, is that overall patient survival is still significantly better than maintaining on dialysis. And with that, if you guys have any questions, I'll be happy to answer them. Yeah. Thank you.
Questions about, I saw there are a variety of different medications that were used, anywhere from Rituximab, Pharmd, Cantab. Was there any impact on the choice of the initial induction agent on some of the longer-term outcomes, especially what we know about Cantab and later AMR?
Right, right. As of yet, so very few of the studies have actually used Campath or have reported them out. The majority have been Desensitizumab and Thymoglobulin. And the studies are just so heterogeneous that it's really difficult to pinpoint those right now. And the ones that did report their different induction strategies didn't really cite any type of change in outcomes based on the type of induction, but it certainly would be interesting to look at, especially with Campath.
And then were there any reports regarding the long-term follow-up infection
Sure, yeah. So again, there's been a variety of things, so like what we saw in the one study, the case of nocardia. So, you know, with plasmapheresis and more immunosuppression, of course, you're going to incur more increased risk. Many of the studies have kind of been a wash. They haven't really seen haven't seen a difference in infection outcomes. One recent one that I actually didn't include but has come out in the last couple of months has shown increased risk of BK viremia, and then ultimately could potentially leading to nephropathy. So certainly there's a whole other risk that you're incurring with these, not just in rejection alone.
I have a comment and a question. When Montgomery was here talking, he mentioned that they do DSAs every 24 hours on a patient like this.
Mm-hmm.
In order to do this at the center, we have to have a whole buy-in from the
Exactly. Yeah, because the biggest thing is you have to hit it up front.
And I wonder whether the economic analysis took that into account. We're using all kinds of
All the actual, you know, I actually don't know. I don't remember them reporting the actual DSA draws. But certainly.
Time involved in that.
Oh yeah.
The other comment I had, when they looked at the difference between the class 1 and class 2 DSAs, did any of those studies look at complement fixation?
Well, there was just the only one that the biggest one that I'm aware of course, is the New England one from last year. And I think that based on those results, that's very interesting to, you know, going forward. These studies, the long-term outcomes haven't yet looked at complement fixing.
I think that might be a big issue in predicting who's going to get
Exactly, exactly.
Well, give an example. What do you mean by that, Dan? When they look at complement fixation, as in a cytotoxic cross-match? Or?
The C1q binding antibodies.
fixing
Oh.
So there was the New England study that came out in the fall that very similar to these Kaplan-Meier curves that showed that negative C1q HLA antibodies had similar outcomes as the, you know, negative DSA, but it was the complement fixing antibodies that showed the profound decrease in survival.
that could be a discriminating factor about which ones would be likely to cause the cancer.
And the labs have the ability to detect those pre.
They have them now, and I'm not sure our lab
Our lab is not,
does it.
I don't know, you guys could speak to that, but I don't think our lab is using those on everybody. It's available. Right, sure.
How much work is involved in determining whether it's complement fixed? It wouldn't be that much work.
Thank you.
So one question, have you come across something doing the bone marrow transplantation?
I have not, but that certainly I think is very interesting as well. Alrighty. Well, thank you guys for listening.